Okay, so now we'll look at osteopenia. I had mentioned osteopenia briefly in the discussion about osteoporosis. So osteopenia, when we look at the bone mineral density, is 1 to 2.5 standard deviations below young normal. So this is when we look at individuals that have this, those are the individuals that are presenting with a high risk of developing osteoporosis. So in many situations, somebody will get diagnosed if they find this out early on. They'll get diagnosed with osteopenia before osteoporosis. Again, this may be present in younger women as a result of anorexia, poor nutrition, and amenorrhea. So, much like osteoporosis, we have again your similar risk factors. Obviously, the idea here is that we want to look to either reverse this process or slow the progression before they actually develop osteoporosis. So if you do catch this early enough and have appropriate interventions, you could reverse it, or at the very least kind of limit the speed at which someone develops osteoporosis. Again, obviously here we're looking at, again, vitamin D and calcium being an important part of this process. And part of what you always want to make sure is, particularly in an individual who obviously when they get assessed with this, you want to make sure they don't have like a malabsorption problem from something like a Crohn's disease. So that's another thing, on top of worrying about, eating disorders and just poor nutrition in general. You want to make sure that obviously if they have good nutrition, that they're absorbing everything. So you want to make sure that they don't have any conditions such as that. And again, the exercise recommendations are very similar to what you would look at with osteoporosis. So there's not a whole lot different that changes with osteopenia. The only difference is that there's fewer precautions with the high impact activities, because the bone mineral density hasn't gotten to the point where it would put them at like an extreme risk for fractures and whatnot. So again, similar, you could go back and review your recommendations if you want to make a couple notes. But there's not really that much different from osteoporosis other than fewer precautions. So actually the individual who is in a situation where they have osteopenia and not osteoporosis, there may be fewer things, well, there would be fewer things you'd have to worry about as opposed to what you'd be dealing with osteoporosis. Okay, now looking at osteoarthritis. So osteoarthritis is a degenerative disease that causes pain, swelling, decreased range of motion in whatever joints get affected. Here we have a couple joints that are most frequently affected. And you could quantifiably look at this. So you could either look at this through you could look at the actual joint degeneration through an X-ray or a DEXA scan. So they usually either diagnose it based off of that or symptoms of deterioration. So the symptoms that an individual has, again, the pain, swelling, range of motion, or some combination of the two. And this could begin as early as 40 years of age. As far as risk factors are concerned, you look at gender, age, race, excessive body mass, prior joint trauma, muscular weakness, estrogen deficiency. As a matter of fact, when we look at this, females are more likely to have osteoarthritis than males, particularly with an increased risk after age 50. Okay, but like I said, it could begin even as early as age 40. And again, I had mentioned some of the risk factors. Again, the causes are largely unknown, but usually through like a history, when someone gets diagnosed with this, you usually either see or the person tells you either a prior joint trauma that happened, they have some type of structural misalignment, which you could see, an individual would be able to see on an assessment of this person. Improper loading patterns are a big problem associated with osteoarthritis too. So for people who are physically active, and they, kind of have this repetitive overload of certain things. We'll kind of talk about how, it's like resistance training or any type of activity, why it's a good idea to not constantly do the same thing all the time, even though it might not be causing problems at the present, it could cause problems down the future. There's a couple different types of osteoarthritis. There's what we'd call idiopathic localized There's idiopathic general, and then there's secondary osteoarthritis, which is associated with a known trauma, or some type of neuropathic problem or a medical condition. So those are some of the different classifications in as far as looking at of osteoarthritis. So looking at osteoarthritis, so we'll talk about some medications. Again, keep in mind there is no cure for osteoarthritis. We'll talk about, again, some medications that get used and some other things that can help, again, outside of surgery and joint replacement, which we'll be mentioning as well. When we look at medications, again, usually when we talk about medications for osteoarthritis, they're primarily utilized for the symptoms, so the pain and swelling that individuals have, that limits range of motion. So again, we have NSAIDs, your non-steroidal anti-inflammatory drugs, your non-opioid analgesics like your Tylenol, acetaminophen, glucosamine and chondroitin supplements, which glucosamine and chondroitin supplements, so glucosamine is a nutraceutical that can assist with pain and inflammation relief and actually possibly cartilage production. So the research on glucosamine and chondroitin is equivocal in humans. In other words, they're not quite sure whether it definitively helps, but there have been individuals who have seen benefits with it. So again, that's something to kind of keep in mind with individuals, or something just in future research to sort of look at. Because there have been some studies that have shown that it's beneficial, however, not to a point where we could say that it definitely works. And then you have your topical analgesics, which help with pain reduction as well. Again, note particularly the side effects with NSAIDs, because again, NSAIDs are probably some of the more common things that get utilized. And again, make sure you review the medications in the medications table in 3.3 at the end of the chapter, again, as you would with all of these situations. Make sure you have a pretty solid understanding as to the types of drugs and, common side effects that you would see for all of these. Again, there's other medications can reduce inflammation or improve joint function. Corticosteroid injections and hyaluronic acid injections are some things that will also be utilized for patients that have joint degeneration. So your corticosteroids are very powerful anti-inflammatory agents, and you can take obviously oral corticosteroids, but in this instance we're talking particularly about a corticosteroid injections, which again, they're very powerful. They get a very direct effect, obviously, with the injections, and again, they're usually going to be prescribed for moderate to severe joint pain and inflammation, particularly if individuals don't get any benefits from regular NSAIDs. And again, they come kind of with their own side effects. There's also the hyaluronic acid injections. Basically, what they are is, again, hyaluronic acid is actually a natural thing found in normal joint fluid. So inside our joint capsules, we know we have synovial fluid. And hyaluronic acid, actually, the idea is it basically more or less helps to increase the joint lubrication. So it almost kind of helps with the production of that it kind of supplements the natural hyaluronic acid and kind of allows some sort of natural lubrication to take place in the joint. So that's the function of the hyaluronic acid injections. As far as the effects of exercise, we know that even in individuals with active osteoarthritis, exercise can actually help with pain reduction. Again, just getting, muscle activity in and around the joint, strengthening the muscles around the joint can specifically help with, counteracting a lot of the issues that come about with osteoarthritis. It can help take stress off the joints. Obviously, part of the big thing in as far as exercise selection is going to become very important with individuals with osteoarthritis to prevent obviously worsening their symptoms. So again, looking at exercise recommendations, again, if you check out table 3-4 in the chapter, there'll be some recommendations. We'll talk about some things here. So aerobic exercise, again, with large muscle mass, again, swimming, cycling, walking, light to moderate intensity, so about 55 to 75% of your max heart rate, 3 to 5 days a week. With your resistance training, at least 2 to 3 times per week at moderate intensity, so 60 to 80% of one repetition max. And then obviously some flexibility exercises. So again, what we're kind of looking to include, as you see with a lot of programming, a little bit of everything, okay? Part of the I guess important points with this when you're dealing with someone with osteoarthritis is, one, obviously you have to look at what joint is involved, and then kind of treat accordingly. So for instance, with your lower extremity, if you have someone with osteoarthritis in their hip, bear in mind the exercises you're picking. You still want to pick exercises to strengthen the lower extremity, but at least initially you're going to want to start and really watch how you're loading the joint. So it's going to be really important in your exercise selection, again, making sure, I always say making sure you kind of have your own personal, pretty big library, if you will, of exercises is really important, because you want to be able to think about how you're loading these individuals with certain exercises. But starting with these parameters that I'm giving you and that are further discussed in the table could be a good starting point. Certainly individuals can progress. Again, someone with the active osteoarthritis is probably not going to be doing a whole lot of heavy, max effort, type, strength training. But you could eventually kind of exceed maybe that 80% threshold occasionally now and then once the individual gets comfortable. And again, plus two, just as we talked about with everything else, you have to look at what's that person's experience. If they have a little bit more experience and they've been active, they're going to obviously progress much differently. If you're dealing with somebody who has strength trained for a long time, and maybe their strength training partially contributed to the osteoarthritis, but they still have some pretty good strength, maybe it's just a matter of kind of getting them away from like certain exercises for a while, or maybe just kind of loading them a little differently, that could certainly help with the process. So joint sprains and dislocations, okay, so a joint sprain is damage to a ligament, okay? So again, sprain is damage to a ligament, a strain is a, excessive stretching or tearing of muscle, okay? So when we're talking joint sprains, we're talking ligaments. And again, very common thing, most likely occur ankle, knee, or wrist. Obviously, lateral ankle sprains are the most common injury, particularly when you're talking a lot of sports. When we're talking joint dislocations, that's when the joint surfaces are actually separated. Depending upon the degree of separation, you could have various signs and symptoms occurring. Again, pain, obviously limited range of motion, numbness and tingling if there's any type of compression or damage done to the nerves. It's one of the, particularly when you're talking your larger joint dislocations, you obviously have to be concerned about other structures being involved. So, for instance, the shoulder is the most commonly dislocated joint. Anytime somebody has a first-time shoulder dislocation, they need to have, x-rays done and everything to make sure that there's not further damage. But you always have to be concerned about nerve damage, particularly when you have a shoulder joint dislocation. So in grading sprains, again, sprains when a sprain gets diagnosed, typically they will give a grade or a degree of sprain. So, and the grades, and you'll also hear, so these are this is kind of like the simple grading. Sometimes people, I'll talk about from a sports medicine standpoint, how sometimes this gets utilized. So grade 1 is a minimal stretch, no tearing, no instability. So basically the ligament's just been kind of stretched beyond its normal limit, it's irritated, but there's no real tearing, and the joint is still stable. A grade 2, it's a moderate stretch, some tearing of fibers, and you notice some instability. And a grade 3 is a complete tear. And sometimes what you'll also hear is you'll hear grades, like you'll hear grade 1 plus, grade 2 plus. Sometimes they get graded like that if they believe. So for instance, they'll say maybe it's like a grade 1 plus. Many times with like the ankle, for instance, more than one ligament, a lot of times gets involved. So there's multiple ligaments around the ankle joint, depending upon how severe the sprain was, or kind of how the foot and ankle kind of was orientated when it was sprained. You can get involvement of other ligaments. So sometimes you hear like a grade 1 plus if maybe, none of the ligaments are completely torn, but there's more than one ligament stretched or something to that effect. You'll sometimes see the plus grading. You don't so much have to worry about that. Most of you won't have to contend or deal with that. But this is at least what we're looking at as far as kind of how you can look at your different types of grades. So a dislocation, again, dislocations are usually going to be caused by an impact or falling. Again, the degree of separation, you look at whether you have a partial or a complete dislocation. You'll also hear the term sometimes subluxation. So when a joint subluxes, it kind of basically comes out and then goes back in. So sometimes individuals will have that happen. The joint surfaces will kind of come, they'll separate, but then they'll kind of go back together. That's what's known as a subluxation. But you could have, varying degrees when a joint is dislocated. So sometimes, for instance, when a shoulder gets dislocated, you don't have a complete separation of, for instance, the humeral head from the glenoid. Sometimes the humeral head will just kind of come out a little bit, not be totally out. It'll kind of ride along the rim of the glenoid, but not be completely out. And then you also, as I said, you have to be concerned about the extent of the overall injury. So, in a simple dislocation, for instance, there's no bone trauma. You can also get fractures associated with dislocations as well. And that's one of the things, particularly, when an individual has a first time, that's why someone with a first time dislocation, you don't reduce that until you get an x-ray and make sure that there's no fractures associated with it. And again, you obviously will have damage to ligaments many times associated with this. So again, it just kind of depends upon, are there other structures involved? Are there other ligaments torn? Are there blood vessel or nerve damage? That's obviously always a big concern anytime, particularly with, large joint dislocations. People get concerned when there's a dislocation at the knee about, damage to the nerves and blood vessels that kind of go on the posterior side of the knee joint. Okay, so medication-wise, usually what we're looking at here, again, your more common pain relievers and anti-inflammatories, so non-steroidal anti-inflammatories, non-opioid analgesics. Again, kind of make sure to be aware, again, of the side effects, some of the more common risks associated with those. So again, when we've kind of been through these before, but make note, again, of the common types and some of the side effects within your notes. As you kind of go through your material. So as far as the effects of exercise, again, for grade 1 sprains, weight-bearing exercises after the initial swelling has disappeared definitely is allowed for improved mobility and strength. And grade 1 sprains, speaking from the rehabilitation side of things, which again, I know, again, kind of separating scope of practices, but usually grade 1 sprains, people can typically get moving on them pretty quickly. And again, the faster you can get, good mobility and strength there, the better off you are. Grade 2 and 3, again, require a period of immobilization and treatment by a rehab professional. So again, you'll need an athletic trainer, physical therapist will probably really need early on to kind of work with them. And again, they don't really tend to, particularly for grade 2 sprains. I mean, obviously grade 3 sprains, you'll have some instability there that might require some further intervention. But those will usually require a little bit more early on with the rehab professional as far as managing that. So again, exercise recommendations, they're similar for both dislocations and sprains. So again, just some general guidelines. So again, rest for 1 week, work on restoring flexibility and strength. And then again, low to moderate intensity body weight exercises 6 to 7 days a week. The flexibility, you could be looking at holding that for about 30 seconds when you're working with that. Again, when the joint's pain-free or in that final phase of strengthening, again, low to moderate joint-specific full range of motion exercise, and then eventually moderate resistance can be added 3 times a week. So again, really depends on your severities as far as how you're looking at kind of managing this from the exercise professional standpoint. Just making sure that there's, complete, the necessary healing to kind of progress their exercises. And again, work in conjunction with the athletic trainer or the physical therapist to kind of get some guidelines on what it is they would need. Okay, so joint replacements. So, joint replacement surgery involves replacing the damaged joint with a synthetic prosthesis to improve function and eliminate pain. Typically, the principal cause of hip and knee replacement surgeries is osteoarthritis. And again, risk factors kind of leading up to that, or just joint replacement in general. Age, gender, body mass, high BMI, developmental disorders, fractures, and any type of injury or diseases leading to degeneration of the joint. As I pointed out here, osteoarthritis is usually one of the leading causes of this. As far as the medications involved, again, you get your various pain relievers that we've already mentioned. Again, your NSAIDs, your non-opioid analgesics. If an individual has severe pain associated with the joint replacement, they might get put on an opioid, which would be for more severe pain. And again, you're not going to want an individual will not want to be on those long term because there could be addiction associated with that. The other things that will usually be prescribed as well, antibiotics and anticoagulants. The antibiotics will usually be given prophylactically to help prevent infections, and then the anticoagulants just to prevent blood clots from forming. Typically, warfarin is one of the more common anticoagulants that will get prescribed for somebody after a joint replacement. As far as the effects of exercise on someone who's had a joint replacement, again, physical activity beyond, again, all of your general benefits that you will typically see. One of the main benefits is to stimulate blood flow because, again, anytime a body part is immobilized, the person could possibly be at risk for blood clots, which is part of the reason why many times anticoagulants will be prescribed. But 40 to 60% of joint replacements, you have an incident of blood clots with. So that's one of the things that you do want to be aware of after surgery. But many times, again, get some information from the physician regarding the individual with the joint replacement. Typically, as the exercise professional, by the time someone with a joint replacement comes to you, for the most part, they've kind of been through all of that early phase where this usually won't be too big of an issue, but it's just something to kind of have in the back of your mind. So I'm looking at the exercise recommendations. Again, if you go to table 3.6, so again, make sure as you're going through all of these, you're kind of looking at those recommendations. So usually what they recommend is at least a 6-month time frame before engaging in vigorous exercise. And again, one of the things I do want to recommend, again, the recommendations they're giving here are very general. They're a good place to start for most people, but also consider the client's prior exercise and sporting experience with the recommendations. So some individuals, depending upon what they've done in the past and or currently doing prior to the joint replacement, they may be able to work out or train with a little bit greater intensity. So it is something to keep in the back of your mind as you're working with people. But typically, after a joint replacement, you wait about 6 months to really so they really get to ramp up and engage in more vigorous exercise. So again, the idea is you want to allow a return to stable, pain-free movement. Again, that'll start with the rehab professional before they begin a resistance training program. So Their early rehab will be conducted with the athletic trainer, the physical therapist. Again, they could begin some low impact, simple aerobic exercise, such as walking and biking. That'll kind of be within the early phases. So they'll kind of limit how much high impact stuff they'll do initially. And then after 6 months, they could begin a more rigorous exercise based on their individual tolerances. Again, from a resistance training standpoint, again, when they start, they'll begin with like 1 or 2 sessions per week, light to moderate intensity, so 40 to 80% is what's recommended. And again, multi-joint exercises are good because they engage multiple muscle groups. And again, you could increase to a few more to 3 to 4 sessions per week, and you can start to ramp up the intensity. Again, particularly consider, maybe the individual was somebody who had strength trained before this. For instance, a lot of power lifters who do continue to strength train, their whole life, even once they retire from powerlifting. If they have to go and get a joint replacement, they still want to be able to strength train. They still typically keep their strength pretty well, later in life. So that might be a situation where you'd want to do that. But, review the flexibility guidelines and everything in this table as well for some of the general recommendations for these individuals. Okay, so next we're going to look at some general muscular system disorders. So we've been looking at things more associated with musculoskeletal injury. Well, here we're going to look at muscular system disorders. Frailty is a condition that occurs in older adults, and this is usually frailty is kind of like a multifactorial, what they call a multifactorial etiology. In other words, there's typically a few different things that contributes to it, to the overall pathology of it. This occurs in older adults, combination of poor health, reduced muscle strength, and then just the reduced ability to engage then in physical activity. And again, a lot of times that comes with just not being, being very sedentary as one gets older. Again, 20 to 50% of individuals aged 85 and older are likely to experience frailty. So obviously, as people are living longer, you see this being a much more common thing. This is the result of age-related decreases in functionality of organ systems. So again, as you get older, again, particularly if you don't tend to lead a healthy lifestyle, your organs and everything just don't function the same way. It's not unlike anything. The older you get, your organs aren't quite as efficient with how they work, and then you couple that with, again, decreased physical activity, it just makes things worse. This is many times associated with other chronic diseases. So we know that, the risk for chronic diseases and things like this starts to increase after age 65. And then coupled with other things, you'll start to get some nutritional deficiencies. Another musculoskeletal disorder, or another muscular system disorder we're going to talk about, is something called sarcopenia. But osteoporosis is also many times associated with frailty as well. And then you also have the increased risk of falling, which with osteoporosis then puts somebody at risk for fracture. So in looking at frailty, again, because there's so many disorders and conditions associated with it, the medications could vary widely. So again, important to be knowledgeable of the effects and side effects. Again, make sure to look at the tables in the back. For instance, beta blockers are a very common medication for some older individuals to take in managing blood pressure, but a beta blocker can also attenuate a normal rise in heart rate with exercise. So we know that with exercise, your heart rate has to go up. If someone's on a beta blocker, that could limit that a little bit more and cause weakness and fatigue. So that's something to note. So when you're looking at those side effects of these different medications, be thinking about how that would impact exercise. Again, make sure you look through a proper screening, because many times you're going to be looking at existing disease conditions that kind of put the person in this situation where they would be looking at being considered having frailty. Effects of exercise, though, so I mean, just like everything else, so I mean, you get an individual who does exercise, who's experiencing this, you have increased just general functional capacity for them, increased neuromuscular coordination, and that's going to help to improve balance and reduce the risk of falls, increase muscular strength, power. Again, that's all going to reduce the risk of falling, improve cardiovascular functioning, which can again help attenuate cardiovascular disease or other comorbidities associated with that. So again, you have your general recommendations in table 3.7. Again, you want to make sure that again, medical supervision of any fitness testing or exercise is recommended. Some of these individuals may have to do particularly some of the early stuff, maybe in a clinically supervised situation, so that's something to be mindful of. And again, that would be something that the physician would likely oversee or recommend maybe first before seeing an exercise professional outside of a medical facility. General recommendation, again, with aerobic training, light to moderate exercise, start really low, 5 minutes per session and up to, 3 times a day. So the idea here is maybe start with short sessions, but maybe see if you can do multiple sessions in a day. So if an older person is obviously, likely you could be looking at someone who's probably retired, so they can probably do multiple sessions in a day. That would be a good way to start. Resistance training wise, again, 3 sessions a week. You're going to want light to moderate intensity, which again, you see in a lot of this, that 40 to 80% one repetition max. So you could start with 1 set per exercise. Again, in all likelihood, individuals in this situation aren't going to need a ton of stimulus to make changes, and then you can kind of work them up from there. But make sure to kind of look at that. Again, you're going to want to look at the exercises that you're going to want to select. The person may not be able to do weight-bearing exercises early on, but maybe you could eventually progress them to that point. And again, here, just some of the things we had already said. Again, light to moderate intensity, 3 days a week for the resistance training. Again, include neuromuscular and flexibility training on most of the days to just help improve coordination and balance. And again, address nutritional deficiencies. So that's going to be something you're going to want to look at as well, to make sure that they're getting proper nutrition, because some of that could be possibly contributing to the frailty as well. Okay, so looking at sarcopenia. So sarcopenia is the gradual loss of muscle mass and strength as the result of age. So this could begin as early as 20 to 35 years of age. Again, depends on various factors. Obviously, inactivity will kind of expedite this. And, it's important to note that, we do have, again, an aging population. We've kind of discussed this already. Because of advances in medicine, people have been able to live longer. So that means that it could possibly, again, set the person up for prolonged loss of muscle mass if they're not staying active. So again, here's your contributing activities: inactivity, poor nutrition, chronic disease, lower anabolic hormone levels, decreased protein synthesis, and spontaneous muscle denervation. So you can see how, again, just in general, and again, this will happen regardless, but maintaining activity can really limit the effects of a lot of this and help to maintain muscle mass. And we know how important it is to maintain strength and muscle, particularly in the lower extremity for individuals. And again, research has shown that people who, have stronger lower extremities do tend to live longer. Part of that is because of the reduced incidence of falls and fractured hips, which then we know as you kind of become inactive, then as a result of that, which then puts a person more at risk for developing chronic illness. So we look at medications associated with this. Again, part of what we'd want to look to do is address nutritional deficiencies. So again, look at a person's protein intake, their amino acid intake, vitamin D. Many times, an individual might get the administration of testosterone or other androgenic substances, things like DHEA, growth hormone, insulin-like growth factor. And again, there's common side effects with testosterone supplementation, so be aware of that. Some of those different side effects that could possibly happen. As far as exercise, again, resistance training can generally reverse or slow the effects of sarcopenia. And again, with that, so and the one item to note is particularly the neuromuscular denervation that occurs with type 2 muscle fibers. So type 2 muscle fibers do tend to get the greatest effect from this. In other words, they're the muscle fibers that will atrophy the most. So actually, some of the resistance training should focus on type 2 muscle fibers. So most individuals, as I say, throughout life should always look to improve or maintain their maximum strength. So, I don't think an individual should ever really, as long as they have some good experience and have worked with it, should ever get away from lifting heavier weights. And there is evidence that, again, muscle power can be lost at a much greater rate than even muscle strength in older individuals. So the more that those type 2 muscle fibers can get worked, you should look to focus on that. Okay, so due to those accelerated loss of type 2 fibers, your exercise intervention should look to both reverse and should look to target those fibers to help generate high levels of force at higher speeds. So again, they tend to find that peak muscle power is experienced at high resistances, that 80 to 90% of your 1 rep max. Now, obviously, somebody who hasn't exercised before isn't necessarily going to be able to go to that right away. You have to work your way to that. But for someone who is currently strength training and aging, you should look to include max effort strength training in the program. Okay, and again, you want to make sure that you manage that obviously appropriately, and you want to make sure that individuals do it safely. But again, certainly, as I've talked about in other classes, heavy weights aren't inherently dangerous, but you do want to make sure that the progression is appropriate. So again, you have table 3.8 to kind of look at your recommendations. Again, with advancing age, make sure pre-existing conditions are considered and appropriate modifications when addressing this. And again, with somebody, you want to maybe avoid some high intensity testing. So if you're getting somebody who's already having sarcopenia, again, I had mentioned that yes, doing max effort strength training is important through life. However, again, considering where a person's at, if you have somebody who again hasn't strength trained, maybe they're strength training for the first time, you're going to want to avoid the high intensity testing if they're already kind of actively experiencing the sarcopenia. So you want to, again, they can start out 2 to 3 times per week, 1 to 3 sets of 10 to 15 reps, light to moderate intensity. You have your aerobic training, again, and your flexibility training. And again, that should be stuff done on a daily basis and encouraged. So constantly doing some type of mobility, flexibility, a little bit each day can certainly be a benefit for that. So again, make sure, again, as I said, through all these tables, kind of take a look at them. There may be some other small items that you want to put in your notes. For the most part, I kind of hit up and summarize them, but make sure to kind of review those in your text and make any notes that you would feel necessary to help yourself. And these are your learning outcomes. So again, go back and see, look at all the different conditions, make sure you kind of understand their pathophysiology. And again, always go back and make sure for this chapter and all of them to look at all of the major medications.